Center, Ahmedabad. He is a member of ACIBP 2020, 2021, 2018 and 19. He is a National Scientific Convener, IAP Action Plan 2020 and 2021, EB member 2018, 12, 9, Chairperson of Infectious Disease 2015, and Academic Coordinator, National Vaccinology Module 2021 and 22. So may I request Dr. Abhay Shah, sir, to introduce the speaker and start the proceeding. And,
Yes.
and Dr. Anupam will be joining.
Sir, I have already joined now.
Sir has already joined. Sir, welcome, sir.
Thank you very much. I'm sorry for the delay. I was stuck in a meeting with the government, this thing on hemoglobinopathies. So kindly excuse me and welcome all of you. I'm sorry, Dr. Balasubramaniam, Dr. Abhay Shah, for the delay. Hello?
Yes, please.
Yeah, no problem. No, please
No
go
problem.
ahead.
No issue.
Yeah.
So
So,
yes, sir. Please go ahead.
yeah,
Welcome, sir.
yeah, I'm audible now.
Yeah,
Yes.
sir, you are very much
yes.
audible.
Yes.
Thank you very much. It's my pleasure to introduce Dr. Abhay Shah, who, more than his abilities and his various other things, is a thorough gentleman, unlike me, who's a rogue. So, welcome, Dr. Abhay Shah.
Yeah.
And along with that, Dr. Bala, sir, we go a long way back, just like Abhay Shah and me. Dr. Bala is a well-known teacher, a great researcher also, and a master in infectious diseases. And we were together as, in one of the EBs together as EBs, and we struck a right chord whilst traveling from the airport to the EB meeting, we stuck with that, and our friendship goes back at least about 15 years. Thank you very much, Dr. Bala, sir, for this thing. Dr. Bala is, of course, was working at Kanchi Kamkoti Children's Child Trust Hospital, which is an excellent powerhouse of training and research in the field of pediatrics in Chennai. So I think without much ado, we have wasted quite a bit of time because of my absence. Can you please start off your talk on infection mimics?
Okay, let me share my screen. Okay. Yeah.
Yes, sir.
Yeah. It's not allowing me. It's not allowing. No.
Admin, can you please take care of this?
Please make Dr. Bala sir this host.
I'm not able to share.
Yeah, you need to be host first.
So he is a host now, co-host. I can see he's a co-host.
Okay.
Let me see again. No, it's asking. No, it's not going to the sharing thing at all. I'll just try 1 minute. Just try
Gaurav?
1 minute.
हेलो गौरव बाला सर को आप वो पोस्ट बनाओ.
No, I'm not able to share the file.
करो सुशील फोन नहीं उठा रहा.
कल ऑलरेडी है कोस्ट है सर.
सुशील को गाइड कर दो ना प्लीज.
No.
Sir,
Okay, sir.
You are already co-host, so you can share.
He's asking for SharePoint and all that. 1 minute, I'll just see. No, I'm not able to share it.
Just I'm calling Sushil, please.
Sushil, maybe we can ask Dr. Bala to log in,
Okay.
log out and log in again.
Okay, yes,
Okay,
sir.
I'll do that. 1 minute. I'll do that. 1 minute. Otherwise, I'll WhatsApp to you, Anupam. You just open it.
Okay.
Anupam, shall I
Sir, आप
WhatsApp
कर
the
दो,
PowerPoint? You can
कर दो,
open it
sir.
there.
कर दो सर, मैं करता हूँ फिर उसके बाद.
Shall I WhatsApp that?
सर आप करो प्लीज, व्हाट्सएप कर दो प्लीज सर.
Yeah, because it's not moving on. 1 minute. Let me see. Just a
Sir,
minute.
you WhatsApp and also log out and log in again.
Yeah. First, I'll do WhatsApp. That's actually.
Log in and log out.
Yeah, 1 minute. 1 minute. Just a minute. Let me WhatsApp to Anupam.
Haji sir.
Yeah, I have WhatsApped the thing. 1 minute. You can open it from your computer. I don't think it's. I'm not able to. I'll try last. I'll go out and just go out and try once more.
Yeah, please.
I'll leave and join. Leave and join. 1 minute.
You are muted, sir. You are muted.
No, it's not allowing me. Some problem with that with the thing. I'm just trying. No.
Sir, try once again, sir. Just see, you have just been made the co-host again.
I just try 1 minute. Last moment. I have WhatsApp to you. If possible, you can open it. No, I'm
Yeah,
not
I'll
able.
do that, sir. I'll do that. I'll just do that.
अनुपम सर आपका आया नहीं है मेरे को.
मैं कर रहा हूँ सर, वो डाउनलोड कर रहा हूँ उधर से.
अच्छा. ये सुशील फोन पिक नहीं कर रहा है.
सर या उस पे भेजो, IAP दिल्ली पे ईमेल पे भेजो, मैं यहाँ से चला देता हूँ स्लाइड.
अच्छा सुशील.
भेज दिया डॉक्टर ललन, आपको मैंने भेज दिया.
मैं इसको भेजता हूँ.
You got the WhatsApp?
यस सर.
Yeah.
आप ईमेल भेज दो सर मेरे को, डॉक्टर ललन सर.
ये डाउनलोड नहीं.
I'm sorry about it. There's some technical issue there.
सुशील तब तक सर को गाइड करो ना, कैसे होता है. सर को गाइड करो आप, वहां से होस्ट बनाओ.
अरे ऑलरेडी होस्ट है सर.
No, you please put the PowerPoint there and somebody can press. That's all.
ओके सर, we are व्हाट्सएप मंगा दो सर, मेरे को व्हाट्सएप भेजो.
सुशील मैं
डॉक्टर ललन सर.
मैं भेज रहा हूँ.
सुशील, तुम्हारा IAP Delhi@gmail है ना?
भेज दो मेरे को.
मैं क्या
Your
पूछ रहा हूँ.
WhatsApp, I have sent it. I'll send it to.
अरे it is IAPdelhi2@gmail.com.
No, it is
Yes sir,
WhatsApp.
yes sir.
सुशील को
On your WhatsApp. It's Anupam's WhatsApp.
Sir, I'm just emailing it to them. Tell me, is
Okay.
Sushil
Okay,
is your...
I will send it to Gautam.
भेज दिया सर मैंने.
Okay, fine.
Yes, sir. I'm doing just now. Just hold.
मिल गया ना सुशील आपको?
मिल गया सर.
हाँ,
डाउनलोड हो रहा 2 मिनट लगे. एक आधा मिनट लगे.
I've sent it to your office person also, his name, GK Gun.
Yeah.
I've
So
sent to
I've-
him himself
yeah,
also.
yeah, yeah. We are organizing it. So it is just being done in 2 minutes. It will be done.
Yeah, that's it. That's it. Please make it full screen.
सुशील नीचे जा करके है ना? हाँ.
Yeah. Okay. Thank you. Thank you. Yeah. Okay. Anupam, can I start?
Sir, please do.
Okay. Okay. Thank you, Dr. Anupam. I'm extremely sorry for the technical issues which have cropped up. Okay. Please go to the next slide. I'm sorry, I'm not able to share the screen from here. Yeah. And the next maybe 40 to 45 minutes, I'll make it brief. Let me share a few cases from my personal file where I had difficulties in dilemmas in diagnosis, particularly to differentiate whether it is infection or non-infection. I thought we will have an overview of causes of infection mimics, clues to infection mimics, and give some summary and take-home messages. Next slide, please. Yeah, if you see this picture, on top you see a line. But if you see carefully, what you see down is a cat. So sometimes a line may look like a cat. Can you go to the next slide? Next slide, please. Sometimes this can happen. A cat may look like a lion. So it may be illusory for the clinician when he is confronted with a child who has multi-system disorder to identify, first of all, whether it is a serious problem or not, whether there is a danger of an infection or a danger of a non-infectious illness. Next slide, please. Let us move on to the case scenario 1, where this was a 3.5-year-old girl child who was previously well. She had pain in the right thigh for 1 month with continuous fever for about 11 to 12 days. First symptom was pain, and the paternal grandfather had active TB and he is on ATT. The child outside received meropenem and vancomycin for about 10 days. The child never got better. Next slide. And the referring doctor did the series of investigations where, if you see carefully, you can see that the hemoglobin, which was 10.8 on 16th August 2017, has come down to 8 in 3 to 4 days or 1 week. In the differential count, gradually the neutrophils are coming down. Platelets, which are 2.1, is hovering around 1.3 to 1.8. And CRP was 4, and rheumatoid factor was done by the primary pediatrician, was negative. Next slide. And outside, they had taken one X-ray because of the pain. X-ray of the thigh because of the pain. I said right thigh. I'm sorry, it's left thigh. They took an X-ray. And if you see carefully the X-ray in the next slide, you see here, there is a very subtle finding which can easily get missed if a postgraduate does not look at it intently. You see here, there is some periosteal reaction in the left femur in the middle. And here again, if you see the metaphyseal ends of the femur, you can make some densities and irregularities. And our radiologist immediately called me and said, Bala, this looks like leukemia. This is not tuberculosis. Next slide. And this finding, as shown in the picture, gave us a clue that this may not be an infection. Next one. Next slide, please. And our dilemma was, what should we do for this child? Hemoglobin is falling, smear not showing blast, but the radiologist says it is leukemia. And we had the option of giving empirical ATT because of contact or proceeding further. That then we didn't want to take a chance. Next slide. We did a bone marrow and it confirmed acute leukemia. And that gave us a lesson. Never forget malignancy as an infection mimic in any PUO. And imagine if somebody had started steroids thinking it is rheumatoid arthritis or some autoimmune disease, it would have been disastrous because the blast would have disappeared. And the moral of the story is never start steroids without ruling out lymphoreticular malignancies in PUO. Particularly if you have a diagnosis of something like Kawasaki or SOJEA or MIS-C, one has to be careful in giving steroids without doing bone marrow. You should always do a bone marrow, check the uric acid and also the LDH and make sure you don't miss a malignancy. Next case. This is a 10-month-old infant, male, who had fever and irritability, only fever and irritability, no other symptoms. And the mother noticed gradually the right jaw was getting swollen. And this child was hospitalized in Hyderabad, given ceftriaxone and clindamycin, and investigated. And basically, investigations except for CRP of 48 rest of the and elevated alkaline phosphatase of 1000, everything was negative. Cultures are negative. Bone marrow was advised, and the parents refused and flew from Hyderabad. And can you go to the next slide, please? This is the picture of this infant on arrival in my clinic. As you see here, the right jaw is swollen. The baby looks literally well. Doesn't look like somebody who's ill. It's quite pink. It's not anemic. There was no organomegaly. Bones were normal. Because of alkaline phosphatase, I searched for evidence of rickets. Nothing was there. So an X-ray was taken. X-ray was taken. And an X-ray gave a spot diagnosis. What was that? It was nothing but Keffi's disease. You can see the necklace-like lesions in the mandible. Very characteristically seen. This is not osteoma or tuberculosis or infection or malignant. Typical cortical hyperostosis of the mandible. Next slide. And how did we solve the dilemma? The dilemma was good history and a good radiology report. And overall, this child never had anemia except for pain and fever. Nothing else is there. No organomegaly, no reduction in hemoglobin platelets. So this was not leukemia or SOL. And next slide. Labs, of course, hemoglobin is slightly on the lower side. Alkaline phosphatase, we all know, can go up in Keffi's disease. Next slide. And we gave only naproxen. Within 10 days, it resolved. Fortunately, nowadays, we have a genetic diagnosis available for Keffi's. We got the report from MedGenome in 4 weeks. We counseled the parents. After that, the child had one more episode of 2 years. And the child is now an adolescent and doing very well. The whole family is grateful to me. Next slide. This is again another case where this is an infant who had fever for 2 weeks. And the parents noticed that there were rashes all over the body, like what you see in the picture. In addition, the parents said child had irritability, crying, and was touched. Wherever the baby was touched, particularly over the bony parts, the child was crying. And the child had hepatosplenomegaly. And when we carefully looked at if you see carefully on the left side of the scalp, there is some seborrhea. Retrospectively, the mother gave a history that there had been 2 episodes of ear discharge. Next slide, please. And we did investigations. Counts were high, 24,000. Hemoglobin was low. Platelets were low. LDH is sky high. SGPT is 500. Hepatosplenomegaly, seborrhea. What is the infection mimic that is likely? Is this infection? Somebody, my PG said, sir, this is scrub typhus. Another PG said this is infection-associated hemophagocytosis secondary to scrub typhus or typhoid. But then we looked at the clinical picture of this, and what we did, we got an X-ray of the skull, and it clearly showed an osteolytic lesion. And even without investigations, next slide, please, we knew that this is Langerhans cells histiocytosis. This is an area. Next slide, please press, please press. Please keep on pressing. Yeah. And this LCH is a funny disease. It is usually diagnosed, picked up very well by dermatologists or by rheumatologists or sometimes by hematologists. A general pediatrician often tends to delay the diagnosis because he always is obsessed with typhoid, typhus, sepsis, viral infection, hand-foot-mouth disease, etc., etc. So this sort of multi-organ dysfunction, skin, ear, bone lesions that we have seen LCH presenting as interstitial pneumonia, LCH presenting as diabetes insipidus due to cerebral lesion. So it can present any way it likes. Next slide. Case 4. This is again another true case. This happened about 2 decades back. This is an adolescent girl, 11-year-old, who had fever, rash, lymphadenopathy, and hepatosplenomegaly. The whole duration of fever was nearly 2 weeks. When the adolescent came to us, she had wheeze, she had hypoxia, she had firm hepatosplenomegaly, she had generalized lymphadenopathy, and she was ill. So our first diagnosis was malignancy. We thought that this is probably some either stage 4 lymphoma or leukemia. To us, it didn't look like infection. But then one has to think of chronic infection like brucellosis, tuberculosis, EBV, HIV, etc. in such situation. So we went ahead and investigated. Look at the blood counts. Total counts very high, 54,000. Smear is essentially okay. The distribution, except for mild eosinophilia, rest of the distribution is okay. Hemoglobin is well preserved. Platelets are 4 lakhs. Bone marrow, we did all the investigation, cultures, viral markers, everything was negative. Of course, those days we didn't have much of immunological investigations. We did HIV and other things. Bone marrow we did, and it was reactive. Next slide. And these are the rashes this girl had. But then, when we are wondering what is happening, the grandmother came and gave us one history. The mother did not know that. The grandmother said, "Sir, this child had a fall in the school 2 months back. We went to so-and-so, a private hospital, and they took an EEG. They prescribed the medicine for fits. And 10 days after the fits, the fever started and the rash started. I thought this is measles and I stopped the medicine. From then onwards, the fever continuously occurred." When we took the prescriptions, and the prescription was for carbamazepine. Next slide. So, next slide. We considered that this is probably a carbamazepine hypersensitivity syndrome. And next slide. This is actually history for us. Next slide, please. This is history for us. We reported the first case of carbamazepine hypersensitivity in India. In fact, this was actually picked up by one of our postgraduates who went and saw the New England Journal, Massachusetts General Hospital case series, and presented a similar case similar to that in an Indian boy who travels to US, develops PUO. It turns out to be carbamazepine who responded to steroid. The same way, this girl, we gave steroids. It was actually pseudo-lymphoma-like illness, secondary to carbamazepine. From then onwards, we always know any PUO, we should always start thinking of a drug fever. And it's a diagnosis of exclusion, it's a diagnosis made by history. Eosinophilia may be there, hyperleukocytosis may be there, OTPT may be elevated, everything can go wrong. And usually when you have a drug fever, you stop the drug within 3-4 days, the fever subsides. And notoriously, anticonvulsants and your cephalosporins are notorious for causing drug fever. That's the story from this case. Next slide, please. Case 5. This is a boy who was well-nourished, 5-year-old. He came with fever, abdominal pain, diarrhea, and toxic ileus. Whole thing was short duration, 10 days. Counts are normal. And as usual, we thought of entering. We started on ceftriaxone. Stool, occult blood was positive. And we added metronidazole. multiple antibiotic, he didn't improve. He started on azithromycin because he didn't respond to ceftriaxone. And on day 11, he developed a sore mouth. Next slide, please. And next day, these lesions started appearing in the legs. And we knew this is a typical diagnosis of erythema nodosum. So in a boy with fever, abdominal pain, diarrhea, erythema nodosum, okay, and the boy who has got ulcers, we knew that this is not infection. This is an autoimmune disease. Next slide. So immediately we called the gastroenterologist. Next slide. We did a stool calprotectin, which was over 2,000. Colonoscopy was done. Next slide. Crohn's disease proven by biopsy. And unfortunately, this boy developed severe uveitis. He's on adalimumab for the last 7 years, and the disease is in good remission. He initially required high-dose steroids and methotrexate. And this is one disease which can mimic TB. Often this is treated as intestinal tuberculosis. And the presence of extra-intestinal clues are very, very crucial. One thing very important in this disease is that your CRP may not go up in Crohn's disease if it is involving only the ileum. If it is more colonic involvement, it may cause more of CRP elevation. If it is only ileal involvement, it may not show up in the elevation of CRP. And we pediatricians who believe so much in CRP may get misguided. Next slide. This is again another adolescent. Next slide. Girl, 13-year-old, 2 weeks, mouth ulcer, some ear swelling, arthralgia, malaise, pallor. And she came in a very sick state with tachycardia and respiratory distress with hypoxia. Next slide. And again, counts, leukopenia was there, differential counts are okay, thrombocytopenia was there, smear did not show any blast, ESR was 120, and to our surprise, CRP is completely negative. It's very unusual, no? ESR 120, but CRP is negative. X-ray showed cardiomegaly, urine showed 2+ albumin, 30 RBC. So something is happening hematologically, something is happening in the mucous membrane, something is happening in the skin, something is happening in the lungs, something is happening in the heart, and some nephritis also is there. So several systems are involved. Is this infection or non-infection? Is it infection, autoimmune, or malignancy? Next slide. And look at the facial profile, typical malar rash. And she had skin lesions suggested discoid lupus. Next slide. And we had a doubt whether she had septic shock, because we initially did give antibiotics. But then the discordance between ESR and CRP gave us the diagnosis. In fact, we started steroids even before anti-dsDNA came because of this discordance. Of course, she made a dramatic recovery, and she's on low-dose steroid with mycophenolate, and she's doing very well. She has not developed renal complications so far. Next slide. Case number 7. This is a 3-year-old boy who had fever for 12 days. He initially had rashes, and the referring pediatrician said the rashes were urticarial. And outside, the pediatrician gave ceftriaxone for fever to cover, streptococcus and enteric. He also gave prednisolone for urticaria. Child didn't improve, and the child started developing some black lesions in the toes. As you see here at the right toe, you can see some black spots. It was referred as scrub typhus with high counts, high CRP, high ESR, high platelet count. We are not sure whether this is infection or vasculitis or both or anything else. Next slide. As he came, as you see here, we can make out cheilitis. The lips are peeling. You can make out irritability, and you can make out erythema of the skin and mild abdominal distension. Next slide. And of course, the BCG scar was red, and perianal rash was there. Next slide. We knew that this is Kawasaki. Unfortunately, we must remember that Kawasaki can coexist with infection. In fact, if you see the literature, 1/3 of children with Kawasaki have comorbid infection, 1/3. But we have seen pneumococcal pneumonia, We have seen RSV. We have seen staphylococcal sepsis with Kawasaki. It can coexist, but most of them are viral infections. Next slide. And this is one clue which may come later, but we have retrospectively diagnosed KD when children come with peeling after a few days of fever or a week of fever after about 2 weeks. Okay, these children need an echo and follow up for 1 year for cardiac manifestation. Next slide. Next slide. Yeah, typical Kawasaki lesion. Next slide. Yeah, typical edema in Kawasaki with abdominal distension. Next one. Okay. Now, what we studied in our institution was to compare cases which are diagnosed early and cases which are diagnosed late. Interestingly, what we found was that most cases who come straight away to the tertiary care center like Gangaram or KKCTS, the pickup was earlier. Whereas those cases which were referred, the pickup was later. This showed in 2012 that there needs to be more sensitization to the diagnosis of Kawasaki. But of course, now it is the other way. Nowadays, postgraduates miss measles and make a diagnosis of Kawasaki in measles rather than make a diagnosis of Kawasaki correctly. There is some amount of overdiagnosis thanks to MIS-C. That's what is happening. And perhaps overuse of steroids for diagnosis of MIS-C. Next slide. And of course, this is what we did again during the MIS-C epidemic. We conducted a study where we tried to differentiate clinical parameters and laboratory parameters. You know, sometimes, you know, scrub typhus, enteric fever, dengue, okay, they can all mimic MIS-C. When we compared the confirmed MIS-C with those who had tropical infections, the differences we found were like this. If a child is older and if the child has mucocutaneous symptoms, CRP more than 100, neutrophils more than 75, and if a child has abdominal pain and the child doesn't have hepatosplenomegaly, the diagnosis of MIS-C is more likely. On the other hand, age less than, hello, what happened? The screen sharing has stopped. Hello? Hello? Hello?
Hello, Dr. Lalan.
Abhay, the screen sharing has stopped. I don't know.
I got it.
Some
Dr.
technical-
Lalan, where are you?
Hello. Yeah,
Ah.
yeah. There is electricity problem in the IAP office, so he's just connecting. Still connect कर रहे हो?
Actually, to continue where I left, Am I audible, Abhay?
Bala, you are audible, but I think
Yeah.
your screen is
Yeah.
not being shared.
Okay. Thank you, Chitkara. Good evening. Yeah, on the other hand, if a child is less than 5 years of age, has organomegaly, okay, and has no mucocutaneous symptoms, CRP less than 100, total count less than 15,000, we observed that it is more likely to be a tropical infection than MIS-C. Next slide, please. Can you move to the next slide?
Sushil, next.
I'm sorry for the whole, yeah. This is case number 8. I have only 4 more cases. I'll try to finish as fast as possible. This is a 3-month-old who had fever and rash for 15 days. Birth weight is 3 kg, now was weighing 4.5 kg, not 45. Had hepatosplenomegaly and seborrhea. It was ill. Leukopenia was there, anemia was there, thrombocyte pancytopenia, SGOT was 360, ESR and CRP were nearly 100, cultures are negative, viral workup was negative, X-ray chest, echo, ultrasound normal, immunodeficiency TB workup negative. Next slide. This is the infant who had marked hepatosplenomegaly with seborrhea. Look apparently well initially. Next slide. So we thought of LCH, we got a bone marrow done. Next slide, next slide, next slide. So we were sure that this is not likely to be infection. But then, to our surprise, 2 things we picked up. The bone marrow picked up a clear hemophagocytosis. Next slide. Next slide. On the same case, we also picked up tuberculosis. This is a twin of an infection and an infection mimic. Tuberculosis along with hemophagocytosis. Unfortunately, these are our early days of hemophagocytosis. Way back in 2007, we lost the child in spite of aggressive treatment for tuberculosis and steroids. And this is the first case of tuberculosis-associated hemophagocytosis syndrome in India. Next slide. Case number 9. This is a CNS problem where a child, 1 year, 3 months old, came with a history of dog bite 15 days before, but then started developing fever, had received RIG and vaccine appropriately, 3 doses by the time they came to us. Child came with drowsy and lethargy suggestive of encephalopathy. And initially, MRI and CT thorax were reported as normal outside. Next slide. And we are not sure what we are dealing with. Is this rabies encephalitis? Is this viral encephalitis? Is this some autoimmune disorder or secondary to the rabies vaccine? This child has developed ADEM. We don't know. MRI was repeated. Next slide. Child worsened. Next slide. And please show the MRI. Previous slide, please. Previous slide. Yeah. The MRI showed multiple changes in the basal ganglia and thalamus. And the radiologist said, sir, it looks like viral encephalitis. And he said, this doesn't look like demyelination. Next slide. And our dilemma was whether this is rabies, whether this is ADEM due to vaccine, or is it COVID, is it TBM, or is it anything else? Next slide. Nowadays, after doing CSF and looking for infections, we always look beyond infections. So this child had lymphocytic pleocytosis in the CSF. Sugar was low, protein was elevated. CSF biofever was negative. COVID was negative. And gene expert is negative. And we did a corneal smear for rabies. It was negative. Next slide. Next slide. Repeat COVID PCR was negative. Next slide. Autoimmune panel picked up VGKC antibodies and GAD antibodies. And we were sure this is autoimmune encephalitis. We gave methylprednisolone, dramatic recovery, child recovered. Next slide. Next slide. Yeah. The bottom line in autoimmune encephalitis is that, next slide, please press. Yeah, please press. Please keep on pressing. Yeah. No, please go to the previous slide. Yeah. Autoimmune encephalitis is a new diagnosis. In fact, the moment you have somebody who has what is called acute febrile encephalopathy, for a pediatrician today, he or she should think beyond infections. For us, it used to be only TBM, then Japanese encephalitis. Now, beyond this, we have to think of autoimmune encephalitis and MOGAD antibody. In fact, even ADEM can present as PUO. And antibody testing, which is now available, is helping us make a diagnosis and it also helps in treatment because we have now potent immune modulators like your steroids, high-dose steroid, methylprednisolone. Rituximab is life-saving in many a child like this. And I would admit that, I'm sure senior pediatricians like Chitkara, Anupam, and Abhay would agree. 20 years back, all these cases, we would have been very happy to treat this as clinically diagnosed tuberculosis meningitis. We would have given empirical ATT and given steroids. Some of them might have improved also. Next slide. This is the last case. Sorry, last but one. This is an adolescent female who had back pain for 1 month. Next slide. Next slide. 1 month back pain. Next slide. I'll go fast. She got gibbous in the mid-dorsal spine. She had gibbous. So the moment you see gibbous tenderness dorsal spine in an adolescent, our diagnosis is straightforward. It is tuberculosis of the spine. Next slide. And you see the MRI, you can see the collapse of the vertebra in D1 level. So we are very confident that this is tuberculosis of the spine. Next slide. Next slide. We did workup for this. And incidentally, when we did a whole body MRI, in addition to findings in the vertebra, we found lesions in the other bones. That is manubrium sterni, clavicle, etc., etc. At that point, there was a doubt about diagnosis. Is this tuberculosis at all? Does tuberculosis produce lesions like this in multiple areas? Very unusual. Next slide. So we did a PET CT which picked up multiple lesions like this. Next one. And then, next slide. We went on to do a biopsy of the bone. What did it show? Next slide. We could not get the tuberculosis bug at all. The histopathology did not reveal a granuloma. Next slide. We are not sure what the diagnosis was. Next slide. Hematological workup was okay. X-ray chest was normal. Next slide. And bone marrow is normal. Next slide. Leukemia was ruled out. And gene expert, multiple places negative. Opthal normal, ANA negative. Next slide. Next slide. And finally, the histopathology, we got expert opinion from 2 senior pathologists. Both of them said this is chronic osteomyelitis. We can't comment on it. We can't see granuloma. This is not tuberculosis. Next slide. At that point of time, this happened about 10 years back. Absence of systemic symptoms, only multifocal bone lesions, chronic inflammation, chronic osteomyelitis, no bug identified, immunodeficiency workup negative. What is the diagnosis? Next slide. We took help from Bristol. Next slide. And Dr. Ramanan, pediatric group. Please go to the previous slide. Previous slide. Hello. Yeah. Dr. Ramanan, this slide. Please focus on this. Dr. Ramanan, pediatric rheumatologist from Bristol, when we took his opinion, he clearly said, Bala, this is chronic, recurrent, multifocal osteomyelitis. And he gave us the criteria because it's an exclusion diagnosis like SOJEA. It fitted in. Next slide. We gave naproxen. Child was doing very well. After this, there was only 1 recurrence. Next slide. We did genetic workup. We could not prove anything. This is an exclusion diagnosis which can which can be easily get mistaken for infection. Next slide. Next slide. Treatment is mainly steroids, NSAIDs. Severe cases, which are called chronic non-bacterial osteomyelitis. Current term is chronic non-bacterial osteomyelitis. Severe cases, biphosphonates may be indicated, steroid may be indicated. There are few syndromes like Sappho syndrome, Majid syndrome, which can also present like this. They are autoinflammatory disorders. Next slide. Next slide. Next slide. Next slide. Yeah. This is the last case. Next slide. Yeah. Keep pressing. Keep pressing. Yeah. This boy came during the COVID times. In fact, these are all pictures sent by the father. This boy, over a period of 6 months, had high-grade fever. The father himself has noticed exudates in the tonsils, high fever, and every time he used to go to a different pediatrician or an ENT surgeon, name any antibiotic starting from amoxiclav to ofloxacin to azithromycin to erythromycin, everything has been given. ENT surgeons have seen. And 7 episodes in 6 months. On examination, the boy is well. No findings at all. He came with an acute episode of fever. That time, we carefully looked at the throat. You see here exudate in the left tonsil. You see here left tonsil. And there was an aphthous ulcer. And I'm going back to the history. The father said, please press, next slide, please. Yeah, press. The father, please go to the next slide. Please proceed. When the father gave a history, every time fever occurred, there were lesions in the mouth like that. We are wondering, how can bacterial infection in the tonsils produce aphthous ulcer? Next slide, please.
Sushil, next slide.
Please press the, yeah, next slide. Typical aphthous ulcer. And investigations were done, everything is normal except for hemoglobin of 8. CRP is done outside, vegetarian, iron deficiency. Next slide. We knew the diagnosis that this is not infection. What is it? PFA-PA syndrome. It's an autoinflammatory disorder. Clear history. So the message is, when you have recurrent oral ulcers, start thinking beyond infection. The only infection which, 2 infections, maybe herpes and HIV, can cause oral ulcers. All other conditions which produce oral ulcer with or without tonsillitis, they are not infective, they are autoinflammatory syndrome. And the proof was prednisolone 1 milligram per kg vanished. Because this was later put on colchicine because of frequent episode. The parents refused tonsillectomy. The boy continues to get once in a while these episodes. Okay, next slide. Next slide. Yeah, previous slide, please. Previous slide, please. So when you have a child who presents with recurrent fever, if you look at this slide, you will get a clear idea how to proceed further. If there is recurrent fever, there are 3 big groups. One is inflammatory infection, chronic infection, or recurrent infection due to immunodeficiency. Second is inflammatory or non-infection like autoimmune disease or autoinflammatory diseases, which are being increasingly recognized. Third is malignancy. And the little 3, the benign ones, are Munchausen syndrome by proxy, fictitious fever or factitious fever. Drug fever may not be benign. It can be like Stevens-Johnson also, or carbamazepine hypersensitivity, or benign hyperthermia. And rarely you may get recurrent fever because of a central cause like familial dysautonomia or ectodermal dysplasia or dehydration. Next slide. If you read the pediatric infectious disease textbook, if you look at PUO in children, most PUOs in children are due to infection, unlike adults, where malignancies are equally important. In pediatrics, number 1 is infection, number 2 is autoimmune disease, number 3 is malignancy, number 4 is miscellaneous. If you look at the non-infectious causes of fever of unknown origin or the infection mimics, collagen vascular diseases like SLE, rheumatoid arthritis come top in the list. Malignancy, leukemia, Hodgkin lymphoma, yes, next. Nowadays, we are diagnosing more and more of HLH, polyarthritis nodosa, neuroblastoma, sarcoidosis, etc. Miscellaneous ones includes Kikuchi, which can present as cervical adenitis, central diabetes, drug fever, factitious fever, granulomatous colitis, etc., and Caffey's disease, etc. Next slide, please. To summarize, next slide. To summarize, please proceed forward.
Sushil,
Hello.
next slide, please. Sushil.
Okay. To sum up, we pediatricians have obsession for infections. So any child with fever, any child with any illness, the first and last diagnosis we make is infection. In fact, I often joke to my students, the whole world is changing. In what way? It's enough. I can. You can stop sharing the screen. Okay. I joke to my postgraduate, the whole world is changing. In what way? We are moving away from an era of infection to an era of autoimmunity, era of malignancy, and era of land phone to mobile phone, and era of natural intelligence to artificial intelligence, and era of heterosexuality to homosexuality. These changes are taking place. But I remember as a postgraduate in Institute of Child Health for 3 years, 1980 to 83, I would have seen only 2 cases of rheumatoid arthritis in my entire 3 years. And I have seen only, I saw only 1 case of SLE in 3 years. These days, postgraduates must be seeing 1 case almost every week. So we are definitely seeing more of infection mimics than infections. So how does a pediatrician approach the diagnosis? Number 1, you should go back to getting proper history. And I always believe, like Sherlock Holmes, we should go into the history, look for clues, and examine like a first-year postgraduate having Hutchison in his hands. Next slide. Next slide, please. And the other important, please go to the previous slide. Previous slide. Yeah. We must remember the uncommon complication of a common disease. Just to give you an example, tuberculosis is a very common disease. Very rare inflammatory manifestation of tuberculosis is called Ponson's disease. Tuberculosis is actually like Shigella, Salmonella. It can cause reactive arthritis. That disease is called Ponson's disease. And that Ponson's disease, which is an uncommon complication of a common disease like tuberculosis, is much more common than the common complication of an uncommon disease. Just to tell you, if you take, right iliac fossa mass, okay, it can be caused by actinomycosis. But for actinomycosis, the GI tract, common complications, the GI is a mass in the right iliac fossa. But basically, actinomycosis is uncommon. If you diagnose tuberculoma, you are more likely to be right. Next slide. We must look at the most common cause of PUO. I already said that. Next slide. Next slide. Next slide, please. Next slide. Next slide. Next slide. Next slide. Yeah. The important points you must remember are, in autoimmune disease, remember, children will not have persistent toxemia. For example, you take rheumatoid arthritis. Child will be ill only during the height of fever. Rash will come only during the height of fever. Rest of the time, child may be all right. In general, multi-system involvement in older children is not at all common in adolescents. Any adolescent with multi-system disease start thinking of an infection mimic. And bicytopenia with very high platelet counts is not likely to be infection. It may be a non-infectious inflammation. High ESR and CRP, it may be SLE or Kikuchi or even Crohn's. High ferritin and LDH, they are close to LHLH. On a similar note, low albumin is an inflammatory marker. The inflammation may be because of infection or non-infection. Hypertension with fever, infection is very, very unlikely. Next slide. You should always take an opthal opinion in any PUO because we should not miss a papilledema or a uveitis. And if there is uveitis, it's very unlikely to be due to infection. Always do a bone marrow before giving steroids to somebody with PUO. And we should not forget that antibiotics do not work like antipyretics. In fact, I joke, ceftriaxone deficiency is not the cause of PUO. And when we are having a child who has a long duration disease, we should not hesitate to reevaluate with history investigations when diagnosis is not over. Next slide. Next slide. Next slide. Next slide. Next slide. You can go to the next slide. Go to the next slide. So what is happening? That's what I said earlier. You can stop here. We are moving from infection towards allergy, autoimmunity, malignancy, and lifestyle related diseases very, very fast. In fact, the percentage of infections that we treat today as inpatients is much less than what it used to be 20 years back, 30 years back. I'm sure with more potent vaccines, with more potent anti-infectives, this problem is going to become worse and worse. And in many a PU, we will have to take help from a hematologist, a rheumatologist, an immunologist, a genetist. And of course, we will rely on exome sequencing for diagnosis. Thank you very much for patient listening. I'm sorry for the inconvenience caused. If there is any feedback, positive or negative, please mail me. Thank you very much. Thank you, Dr. Anupam.
Thank you very much, sir. It's an excellent lecture which you gave with great examples. In fact, I remember, that if you are dealing with any so-called...
Please stop sharing the slide. Please stop sharing the slide, Anupam. Yeah, thank you.
So
Yeah.
any patient whom you're thinking has got rheumatoid or any of these immunological diseases, and you get a fall in the platelet count or near normal platelet count, you should think that your diagnosis is either wrong or your disease is taking off and going into macrophage activation syndrome. One. Number two, if you have a patient with rheumatological problems and you find that the patient is looking sick and your ESR has fallen, it's an indicator of macrophage activation syndrome. Because, and the third thing which Sir said, patients who are small, kids who are small, less than 2 years of age, and have come with so-called LCH and have hepatic involvement, they have a very bad prognosis. They usually do not survive because the disease is very aggressive in these patients. I'm talking of your patient which you were thinking that this could be tuberculosis with macrophage activation syndrome. But when you have hepatitis along with it, usually the patient has a bad prognosis. So I remember another great pediatrician or teacher we have is Dr. Amdekar. He always insists that if you have a patient in whom you have given an antibiotic and the patient is not responding, you give another antibiotic, the patient has still not responded, and you think of starting a third antibiotic, stop, beware, and he uses very harsh words, but I would say stop, beware, and look for some other cause or some other reason for the fever than just giving haphazard antibiotics, etc. So thank you very much. Dr. Chitkara is there, Dr. Abesha is there. Your comments, sir.
Okay.
Yeah.
So, Dr. Bala, I would not say excellent, but a fabulous presentation. A fabulous collection of cases.
Sir, I don't like this one-upmanship. मैं
नहीं
excellent कहता
one
हूँ, आप
upmanship
fabulous
नहीं.
कह देते हो.
अरे सर सुनो तो सही.
We are too good.
वो
We are too
भावना
as friends. So don't worry.
अनुपम भाई भावना को समझो. So I was today you reiterated Dr. Bala that if I call you a walking encyclopedia, I call you one of the eminent pediatrician and an eminent teacher, I have not been doing anything wrong. You have set a very high benchmark for all of us to consider you to be as inspirational. Number one. Number two, I am sure this activity was directed more towards postgraduates and especially those DNBs, because I know Anupam is into that. So you have delivered very concrete messages. And all of us at this age have gone through 3 phases of evolution. If 20, 30 years back, we taught that everything fever is infection, 90% of the time we were true. Then came an era where it was not actually infection, but we thought of, all those other than infections, malignancies, connective tissue disorders. So that was a second phase. Today is the third phase, where dysregulated immunity is probably paying the havoc. And most of the times, this dysregulated immunity is post-infectious agents. So while you do not need to treat that infectious agent as of now, it is that dysregulated immunity causing all this devastation is what requires treatment. So therefore, I'll not be surprised if my postgraduates today go with an idea, sir, तो हर बात में steroids देते हैं या IVIG देते हैं. So this is a new found dictum. But then the clear message is one has to really weigh the pros and cons rather than have a black and white distinction between a dysregulated immunity versus a non-infection versus an infection. For example, Dr. Anupam, I may take 2 minutes if I am allowed to, but I am going to deliver concrete messages.
So please go ahead.
Okay. So the first section, where even if it is a short-term fever, my postgraduates, my students, my subordinates should remember these short-term fevers are 90% viral in nature. So therefore, no antibiotics till you have a certain diagnosis. Anything between, let's say, 3 to 7 days, probably an infection, and you all know the common infections or the tropical diseases, you treat them, but following an evidence that you get. And the evidence will only come if you don't misappropriate or mistreat in the first short-term fevers with unscrupulous antibiotic prescriptions. So definitely in anything between 4 to 7 or 8 days, you'll get a diagnosis of an infectious disease. Third, if you cross somehow first or second week, you really remember that those acute infections are over. Some of the subacute kind of or a persistent kind of an infections may be important, but now they are much fewer than the alternative non-infective diagnosis which are to be there. For example, TB, so unscrupulously diagnosed and treated. Fortunately, last few years, the emphasis on a microbiological clue has really helped us not to go for empirical TB treatment or a trial, TB trial. So that is another lesson we learned over the years. And fourth and the last is that remember autoimmunity, those vasculitis issues, connective tissue disorders are the in thing. Be it triggered by these infectious agents, but by that time you don't need to treat any of the infections. You only need to trigger what is going wrong because of a cytokine surge or an other immune markers or immune stakeholders which are there, which are now causing these particular symptoms. So if my postgraduates today learn these 3-4 things, they clearly get a point not to misuse antibiotics and be an antibiotic steward, never to miss a diagnosis just because you thought fever is an infection, and treat appropriately rather than jump on conclusions with IVIG and steroids being used left and right without information about the diseases. I think I have delivered the messages, and Balaji and Anupam, you will agree with me.
You can't say it better. Nobody can say it better. Chitkara, I'm your fan and I'm your admirer. This is expected from you. Thank you very much. What you
But
said
sir,
is right.
a shade lesser than you.
Oh, okay.
Dr. Abe?
No, sir. Yes, Dr. Bala, as usual, it was an excellent deliberation, and all the cases were actually eye opener. So when fever comes to you, usually we start with the antibiotic. If the antibiotic is not working, we go for some investigation. Then if the ESR is high, CRP, we again go on increase the spectrum of antibiotic. And as rightly mentioned, when two set of antibiotics not working, I think probably there is a right time that we need to change your diagnosis. That is the most important thing. Second, in any undiagnosed case, you should not give the steroid. It will mask your malignancy, it will mask the evolving disease, and the patient will be ending with the complication. And most of the autoinflammatory and autoimmune disease, if there is thrombocytosis, but if the child starts having thrombocytopenia and is seemingly not doing well, probably you have to think of the macrophage activation syndrome. And again, when there is a paradoxical situation, when the ESR is falling and CRP is rising in an unwell child, again, is a sign of HLH. And last but one not very important, when all infections are ruled out, but when the child has got the bony pains, never ever neglect it, it can be a sign of leukemia. I think almost all have been covered very well comprehensively, summarized very well by master of Dr. A.J. Chitkara. So I have nothing much to say, but I would have been very, very happy and a proud moment for me to be a part of this CME. Thank you, Dr. Anupam Sadhu. And thank you, Dr.
Thank you
Bala.
very much, sir. Thank you, everybody, and thank you to the participants who, despite all the glitches, were there in good numbers. And thank you, Dr. Abesha, Dr. Chitkara, and of course, Dr. Bala Subramaniam. Thanks a lot, and good night, everybody.
Anupam, apologies for the slide because I didn't
Sir,
anticipate that. I don't know
doesn't
what
make
the
any
technical.
difference, sir. It's our pleasure.